Welcome back, everyone. I hope you enjoyed your lunch and had a great networking session as well. We'll move on to the third panel discussion of the day. So in our previous discussions, we have covered the signs, symptoms, quality, role of hypertension, etc. in stroke. Now, another key aspect is collaboration. Even in our audience today, we have people from various verticals of healthcare, and I'm sure you will agree that it takes the efforts of all the different disciplines to come together in order to give complete care to stroke patients. Let us begin with our panel on empowering collaboration, strengthening multidisciplinary approaches to stroke care. Please join me in welcoming our esteemed panelists. May I please have on stage Dr. Pallab Bhattacharya, Ph.D. Associate Professor, Department of Pharmacology and Toxicology, National Institute of Pharmaceutical Education and Research. Dr. Sanjay Shah, Head Emergency Department and Senior Consultant Trauma Surgeon, Apollo Hospitals International Limited, Ahmedabad. Dr. Tausif Thangalvadi, VP Medical Operations, RED.Health. Ms. Athira Hareendran, Neuro Rehabilitation Nurse Councillor, Fortis Healthcare, Noida. Dr. Udit Saxena, Principal GMERS, Sola, Audiology and Speech Language Pathology College. And Dr. Biren Chauhan, Group Chief Operating Officer, Sunshine Global Hospitals. Along with sharing his views, Dr. Biren will also be leading this discussion as the panel moderator. So over to you, Dr. Biren.
Good afternoon, everyone. And I must congratulate team of VOH and the distinguished panelists which are present here for this today's session. Post-lunch, it is always difficult, and we will try not to bore the audience with a lot of jargons. We'll try to make it very, very simple. And I hope rather than food collaborating with all of you, the thoughts of panelists will collaborate with everyone. Just to give you a glimpse, stroke conclave. What is the rate of incidence of stroke? Can anybody raise the hand and tell? Anybody from the students or? Please, anybody. Okay. Can anybody else? Yes, please. Okay. Last chance. Anybody wants to try? Somebody from the back. Just stand up and say. Okay. You can correct me. Every 40 seconds, one stroke case reports or diagnosed. And rate of death due to stroke, every 4 minutes, one death. So that is more than 15% of mortality. And do you think, or do we think that only the outcomes can be improved? And those, remember, 6 stroke patients, 1 expires, 5 survives, and out of 5, more than 50% cannot obtain the full quality of life, right? And that's where I think the role of collaboration comes in. Because only neurologist, emergency physician, or a neurosurgeon cannot single-handedly change the scenario. And that's why we are having this particular panel discussion. So it is very, very important. And let me start with my first questions to Dr. Pallab, that you are from the NIPER Institute doing a lot of research activities. Just tell us that what are the recent innovations which are happening in the stroke care management from the pharmacology and toxicology perspective, and what's there in the pipeline?
Thank you very much. Thank you, Voice of Healthcare and Indian Stroke Association, for bringing me here and such a good platform to share the views. So we need to understand the facts. All the medicines that are used for the treatment of stroke are somehow the outcome of the pharmaceutical research. If we are talking about antihypertensives or lipid-lowering drugs or anticoagulant or antiplatelets, everything didn't come in a single day. It is the outcome of research, pharmaceutical research, that has evolved eventually. Now the bottleneck of the whole theme is that lab researches which are going on, lab research coming out with many new molecules, thousands of new molecules. But when we are talking about the success stories of those molecules in the clinics, that do not shape up well. So we need to find what is the reason behind it. But apart from that, out of these molecules, we are getting one molecule which is very effective. Recently, we had a molecule called sovateltide, which came out after 7 or 8 years of research. And that is actually an endothelin B receptor agonist, and which is preferably doing great in the stroke patients. So at one hand, we are doing many research on many molecules which are not shaping well in the clinics. On the other hand, we are coming up with some molecules which are effective in stroke patients. So what is required now? The requirement is innovation. Requirement is doing research which can translate and connecting to the clinicians and understand the requirement and the needs of the patient. So as I represent an organization which comes under Department of Pharmaceuticals, Government of India, I can say that a lot of funds have really been pushed now for drug discovery, and that too in non-communicable diseases. We also have huge funding for cell research, and now what the new innovation coming out in stroke is somehow the cell therapy and immunoglobulin therapies. And I can talk in the perspective of my lab. My lab is really working towards cell therapy and immunoglobulin therapy, and also this pandemic has taught us that how a drug can be repurposed for a disease. So we are also exploring repurposing of drug that could work in the extended time window after stroke insult. So we are working relentlessly to innovate something, and hopefully, as I mentioned, that in last 7 years, the new molecule came at sovateltide. Maybe in coming days, we will have some new molecule which can be really beneficial for stroke patient in clinics in the extended time window. Thank you very much.
So my next question is to Dr. Tausif, who deals with RED.Health and the ambulance drivers, right? So we have always encountered that the drivers drive the fastest speed when they enter the hospital compound, right? And to save the golden period, right? So, and that is very, very important. So what are your views that how the ambulance domain, what are the technological innovations which are happening in your space before the patient reaches to the emergency department?
Thank you, Dr. Pallab. First of all, I would like to thank VOH and also the Indian Stroke Association for including a pre-hospital care organization into this panel. Now, when we look at, let's say, the AHA guidelines, which talk about how we can improve the recovery from stroke or reduce the morbidity from stroke, there are 8 Ds. The first 4 of them, that is detection, dispatch, delivery, and door, is all pre-hospital care. The next 4 happens inside the hospital. So for somebody with a stroke to get the right treatment at the right time, them reaching the hospital early is very important. The time window available for stroke thrombolysis is only 3 hours, now extended to 4.5. And we know in our country, most people sleep over it, sleep over their stroke symptoms. They think this will become all right by morning. If it doesn't become all right by morning, then let's go to the hospital. Already by then, it's too late. So the pre-hospital care work becomes very, very important in such a situation. So this is where we come in, right? First and foremost is the training. The training, like Sir rightly said, is for ambulance drivers about the urgency of the situation and also how to recognize that this person may be suffering from a stroke. And this is not just for ambulance drivers, it can be extended to EMTs, nurses, and even the general public. Fortunately, the mnemonic for this is very, very simple and easy to understand. People talk about FAST, right? FAST. Facial weakness, arm drift, slurring of speech, and the time when it all started. Unfortunately, even when you do FAST, you can miss 18 to 20% of strokes because it's not looking at posterior circulation strokes, only at MC and ACA strokes. So for posterior circulation, they added 2 more. That's B fast. B is balance, E is for any problems with eye, right? So B fast. This can identify more than 95% of strokes, which is a good place to be. Maybe we can get better. And then additionally put in a headache and maybe we are better than that. This is the first step. It's the training that we have to do for everybody. But coming to technology, right? Technology now, we are going to 5G ambulances. 5G ambulances allow us to feed the vitals of the patient directly to the ER doctor or the team at the hospital that's waiting for them. So they know what vital signs are coming in, blood pressure-wise, pulse rate-wise, oxygen level. Even we can feed in ventilator, vitals, ventilator numbers. We can also give syringe pump, what drug is flowing. All of this is coming in now, plus a live feed where the doctor can directly see the patient. Yes? This is what ambulances are now working towards. When these 5G ambulances come, and the doctor, like Dr. Sanjay, we are emergency physicians, so I can take his example now. When he's eagerly waiting for his patient and he knows there's a stroke patient coming, he can now actually see the patient. So when you have these, have a 60-minute window period within which you're supposed to diagnose, get the CT scan done, and also get the thrombolytic in, can we reduce that time? Can we reduce the door to CT scan time from 10 minutes to 1 minute? Because as soon as he walks in the door, he gets into the CT scan. Doesn't even have to come to the ER because the doctor's already diagnosed that this is a stroke patient. So that already is reduced 10 minutes. Get the CT scan and then come back to the ER. Maybe the door to needle can become 30 minutes instead of 60 minutes or 45 minutes for that matter. We can reduce the time. That is where technology is changing everything. Now we can start the treatment in the ambulance itself rather than wait for the delivery of the patient to the emergency department. Thank you.
Right. So coming to Dr. Shah, as a trauma surgeon and the ER head at Apollo, can you recreate the scenario for this initial assessment of a stroke patients in a hospital and how you deal with your resources and the urgency of time? You are literally fighting against the time. So how do you manage the ER department when the stroke patient comes?
That's what is important. I think, yeah. That's what I will continue with Dr. Tausif. Once there is emergency ambulance which has come up, and any patient who comes in emergency department, the role is very, very vital to diagnose first that whether the patient is having such suspected stroke or not. And stroke is one of the very common neurological emergency in the emergency department. And all the person, right from nurses to the doctors, they should be able to understand the dynamics which is going on for this patient particularly, that this patient requires a significant amount of collaborative movement, right from nurse to doctors to technician, and coordination. It is very, very vital. And because everything is related with the time-sensitive scenario, all the patients of suspected stroke patient within to be diagnosed in couple of minutes for initial assessment and categorization as per the priority of their ABC. And then as per the institute protocol or most probably international AHA guidelines, that you should have availability of in-house CT or MRI if it is, then it should be diagnosed within less than 20 minutes. And obviously this will help in early thrombolysis within 60 minutes, but by and large it should be done within 40 minutes to save more brain. And that's how the role of emergency physician is very vital, not only from assessing, diagnosing, monitoring, and doing active intervention in terms of IV thrombolysis along with neurologist or interventional neurologist, and then obviously for monitoring as well. Now, subset of this patient might require further intervention in terms of if it's a large vessel occlusion, it might require mechanical thrombectomy and again liaising with cath people. Pharmacy, intensivist, if patient requires shift to ICU, all these things goes in a very cohesive fashion. And until and unless you are having significant amount of drills, or if you have a more number of footfalls of in suspected stroke patient in ER, this will help ER to be stroke ready, hospital or stroke ready ER, and hence it's like liaising with all. And not to forget, lastly, it is though neurologists have more of a driving seat here after diagnosing, but I would say that emergency physician and their team will help in documenting, taking consent, monitoring of this patient, and liaising with other department as well. So it's a team approach.
Very well said. Good ER department always improves outcomes across specialties. So that's a well-known fact. So now coming back to the nursing practitioner, Ms. Athira, you are the specialized neuro rehab nurse practitioners backed by a good
Yes.
team. What are your thoughts how the neuro rehab nursing care can actually shorten the length of stay and improve the quality of life in the stroke patients?
Thank you for the question, sir. And thank you, VOH and Indian Stroke Association to give me an opportunity to take part in such a great dignities on the stage. So, as a nurse, I can tell that because see, if a patient admitted to the hospital post-stroke care, the nurse is the one who is taking care of the patient 24/7, round the clock with the patient and giving whole care to the patient. So the nurse should be empowered enough to take care of such patients in the hospital. And in some settings, I saw that in some of the hospitals, the nurse may not be identify the symptoms, the deterioration of neurological deficits in post-stroke patients who were admitted in the hospital. So in such cases, the patient may deteriorate and the physicians will be notifying after some time, or like major deficit will be happening to the patient after that. So I must say that the nurses should be empowered enough, and the training and retraining of the nurses should be done enough for that. And the MRS score and BI score, which we were calculating. I'm a neuro rehabilitation nurse. I'm working as a rehabilitation nurse in the hospital. So I am the one who is doing the MRS scoring and BI scoring to assess the self-care deficit of the patient. So it's the responsibility of all the nurses, not only the SPOC person, but all the nurses to assess the self-care deficit, because we know that the self-care deficit is the major problem the patient who is a survivor of a stroke will face, and he have to live with that disability in his whole life if he's not getting well. So the problems like dysphagia, like swallowing difficulty or seizures, and a fall due to the disability of some of the limb. So this may cause a long-term, long-standing problem to the patient. So I think all the nurses should be empowered and trained enough to identify such deficits, such problems in patients, and to notify the physicians as soon as possible. And also, they have to be trained to collaborate with all the multidisciplinary teams, like for the self-care deficit, to train them to become how to get their self-care done by themselves with their ability now present. So that should be done in collaboration with the physiotherapist. The diet should be planned in relation with the dietitian. So the nurse should be empowered enough to do all these things together so that we'll achieve a good patient outcome. Thank you, sir.
Right. Lastly, coming back to Dr. Udit, you are heading the Speech Center and Audiology Center at GMERS Sola, Ahmedabad. What do you think how your department contributes to improve the quality of life for the stroke patients?
Hello. Good afternoon, everyone. Thanks for having me here. Thanks to the organizers to inviting me. So audiologists and speech language pathologists can play a very important role in the rehabilitation of stroke patients. The role is very well established in Western countries, but in India it is not well understood. So there are various problems which can be seen in a stroke patient that can be taken care by audiologists and speech language pathologists. Now these are communication problem, which is a combination of hearing, speech and language. And then you have the problem of vertigo, tinnitus, swallowing problem, and other associated problem like memory loss and dementia. I'll just try to quickly glance through. Now communication. Hearing, speech and language, normal hearing, speech and language is very prerequisite for communication. Now communication is a very complex process, and it has to be coordinated by various brain areas. Now we say that we hear the ear helps us in hearing. That is true, but it gives you only the sensation of the sound. But the understanding of that sound, what does it mean, that happens from auditory nerve to the auditory cortex in the brain. The whatever we are hearing gets decoded and finally we understood. And whatever we understand gets stored in the language area. Now later, as and when it is required, like now I am speaking to you, it is something which is stored in my language. So as and when it is required, brain areas which is responsible for speech identify the articulators, the system which are involved in the speech and stimulate it, so that the words, sentences and phrase I will be able to speak. So this is the complete process. Now if any brain areas which is involved in this process gets affected by a stroke, then the person will not be able to speak. This is the communication problem, and the prevalence of communication problem in stroke is almost 1/3 of the patient shows this problem. This is the hearing problem which I told here is happen after the stroke of the brain, but there can be stroke of the ear as well, where the person completely stop hearing the things. Okay. Now these are the primary effect. There can be secondary effect as well. So what research suggests, if there is hearing loss, it can enhance the process of cognitive decline. Now the patient of stroke are already vulnerable to cognitive decline. So if hearing loss is there and is not assessed and managed, they may be more vulnerable to it. They may develop that problem even faster. Right. And the next thing is the dementia. Now, the memory is of two types. One is verbal memory and a visual memory. So visual memory is what we see and get stored in the visual areas, and verbal memory is what we listen and stored in the brain, as a verbal memory. Verbal memory is more or less is language, and if that problem is there, our speech language pathologist can intervene. Now moving on to the next one, which is vertigo. Vertigo in simple language is a balance problem. Now balance problem it can be two types. It can be a central vertigo or a peripheral vertigo. Now central vertigo can be due to the various brain areas which are involved with the balance. And peripheral vertigo, it can be due to the vestibular problem or vestibular nerve. But it is very important to differential diagnose between the two for the management purpose. Now the audiologists are the trained professionals who can do the assessment and management of the vertigo things. Next thing is tinnitus. So tinnitus is the perception of any sound when the sound is not present. So imagine that sound is not present but you are hearing, and it is very annoying problem. It is so annoying that in US at least 5 to 10% of the people with tinnitus try to commit suicide because of that. And this problem can also, these stroke patient may get this problem, and you can understand how this can be big problem for these patients. The prevalence of tinnitus and vertigo in stroke patient is not well documented, but in my clinical experience I have met quite a few patients who are reporting of these problems. Now the next problem which I am going to discuss is a more prevalent problem, which is a swallowing problem, or the other word is dysphagia for it, which is prevalent in 25% to 50% of the patient. Now swallowing has three phases: oral phase, pharyngeal phase, and then the esophageal phase. And the speech language pathologist, if the problem persists in the oral phase and pharyngeal phase, then a speech language pathologist can help. So these are the various problems in which audiologist and speech language pathologist can help. But what happens, these are more related to the quality of life. That's why it is more overlooked. Correct. And we have to pay attention to this. And what is more important is that we should make a standardized protocol for periodical assessment of all these things.
True. Very well said, Dr. Udit. Moving to the next round of questions that I have for the panelists, I'll quickly go to Dr. Pallab. One of the peculiar problem of the research industry is that whenever the successful research happens, it takes a lot of lead time or a lot of years before it reaches to the market and ultimately to the patient for their own benefit. How can this duration can be shortened?
Very valid question. So as I have mentioned that this pandemic has really shown us a path. So the molecules which are already in the market, can these be repurposed so that we can shorten the time of selecting a molecule for stroke intervention? So a vigorous research is required in that. And the most importantly, we have to have a connect with the clinicians. We have to understand what are the limitations of the present drug and what the clinicians feel, how it can be innovated or it can be transformed into an effective therapy. So in my view, what I feel that just doing research in isolation is not going to work. As was the theme of this session mentions, we need to collaborate. So it's not only the clinician we should collaborate, we should also collaborate with the engineers. We should also collaborate with other stakeholders to make the research effective. Apart from that, what I feel that the research, the kind of research that India is doing now is going to shape up well in next 10 years. The Western world are ahead of us. They did it well before in advance, but nowadays what we are doing, we are really on track, and the government is really boosting how we can expedite the research and taking it from bench to bedside. And that we have really, India has shown during the pandemic how they have expedited the vaccine in the market. So this kind of strategies should be followed to take a new molecule to the market as soon as possible.
Right. Pre-COVID, I think we had very less number of CTRI approved, registry or, places for where the research can happen, for drug trials can happen. And post-pandemic, I think it has multifolded, right? So India is improving in that scenario. Coming back to Dr. Tausif, you are quickly innovating within your space, right? But what are your expectations from the policymakers, governments, and the other stakeholders for optimal stroke care? Because if the ambulances are innovated, but if the ER department, as someone in the previous session said, district hospitals should have a stroke-ready centers, right? If that is not there and you are reaching your patient to that place where the stroke readiness is not there, then ultimately the outcome will not improve. So what are your thoughts on this?
Absolutely, Dr. Pallab. Like you said at the beginning, ambulance drivers are the ones who drive the fastest. But if they don't know where they have to go, what are they doing, right? It's just rash driving. So I was very happy to hear the previous session, Dr. Meenakshi said her hospital is now accredited with the standards generated by the ISA and also with the QAI, right? So it's very, very useful for us. So once we have this sort of an accreditation happening, and I saw some of the WSO work, the ISA work that's happening as well, it becomes very easy for me as a pre-hospital care provider to know where to take these patients. I've had the fortune to work in both a secondary care hospital and a tertiary care hospital. The secondary care hospital did not have an MRI or a cath lab. So you cannot call it a comprehensive stroke center. But whereas a tertiary care hospital where I worked had both. So there you could do end-to-end treatment of a stroke patient coming in. So given a choice, I would always take them to a comprehensive stroke center. And that is important. But today's day and age, whatever innovation we do inside the ambulance, we don't have visibility on which are the hospitals in a particular region which can handle stroke well, and how do I take them there? This I don't have, right? If I have, it makes my job so easy, and the overall impact to the community is huge. It's phenomenal. And for this, of course, a lot of us have to work together. Collaboration is key. And we need a set of guidelines to come in. We need ER doctors, neurologists to then accept these guidelines and then get themselves accredited. So the job of the pre-hospital care agency becomes very simple. We have very clear idea. I can make proper protocols. If you're in this geographical area, these are the hospitals you need to go to. If you're there, these are the hospitals you need to go to. Otherwise, going from one hospital, then saying, oh, they are not equipped for it, then going to another hospital, or the hospital will keep them inside, and then say, okay, I've done these tests, now he needs to go to another center. And here, time is brain. Only 3 hours, not more than that. And already the patient may have not come within those 3 hours. How do you manage that? That's important. So the accreditation standards really help. Thank you.
Right. Coming back to Dr. Shah, what are your thoughts on protocols and evidence-based care and the standards and that can transform the way we are managing stroke right now?
I think I would say this question is the crux of this collaborative session as far as the in-hospital care of the stroke is concerned, though there are multiple verticals, right from pharmacotherapy to ambulance and nursing care and all. But if patient is landing up in emergency department with acute stroke, more than 10 verticals of in-hospital agencies or different departments are going to play sooner or later. And what happens that if everyone works in their own way or not being identified that whether I am required for that patient or not, then this work is going to go very chaotic, and it is going to have obstacle at each and every level of the care that patient is going to receive, right from diagnosing to further treatment. And many of the hospitals, as rightly mentioned, that may not have a good emergency department to identify stroke condition, early ruling out the stroke mimicking conditions. And hence, if we have certain kind of protocol, like what we practice is a code white for last 3 years or more than that, that all these 10 agencies of hospital, whether it is emergency physician, nurses, radio technician, radiologist, neurologist, pharmacy or cath lab and all that. So if they know this situation well in advance, right at the presentation of the patient in emergency department, then they can take their position wherever they are supposed to, and they know what are their role in this patient at what point of time, and this obstacle would be already removed of that lagging or inefficient care. And this improves the overall protocol-based care in timely fashion. So rather, as per the AHA criteria, we can reduce nearly half of that target lines, or what we call it as a quality indicators for this patient. So accordingly, patient's outcome would be much better. As rightly mentioned, everyone knows time is brain. And many lakhs of neurons would be saved by saving even 5 minutes or 10 minutes of early diagnosing, early intervention, maybe early thrombolysis or mechanical thrombectomy, whatever is required. So this is really collaborative approach. You can put this code of whatever color code of that hospital. By and large, it is being practiced as code white, or it can be code stroke. And that's what it makes hospital ready for the stroke patient. And obviously QI is working along with this, and this will further help in patient awareness as well as community awareness about that. Thank you.
So teamwork really matters to improve the outcomes. Coming back to Ms. Athira, everybody talks when it comes to stroke about the managing the golden hour, but golden hour is only 20% of the entire length of stay for the patient, and we often forget what happens after golden hour, the nursing care, the rehab care. Can you share some of the success stories where nurses made positive impact?
Yeah, obviously, we have so many success stories in our hospital. So the first and foremost thing we have done in the hospital is a code fast criteria. Like any of the patient who came with the be fast symptoms, so we will be categorizing that patient and informing all the nurses, because all the emergency nurses were trained to identify if the physician is not present or he may be busy with some other patient. So they have to identify the symptoms of stroke. So first of all, that thing was achieved, and many of the symptoms were caught, and many of the patients were rehabilitated and were thrombolized as well. And we have achieved the door to needle as well as door to grow in time also. And the next thing is the post stroke care. The major difficulty I felt was like dysphagia in patients. Most of the patients were discharged after weaning from the Riles tube, and they were getting coming back with aspiration pneumonia, like histories and everything. So we, at the peak of 2020, many patients were there who had a history of aspiration, and we sit together with the panel of doctors and everyone, and we discussed, and we decided to do a swallowing assessment for the patient regularly. If the patient underwent every thrombolysis after 24 hours, and if the patient is not on the golden period and he was not thrombolized, then after 8 or 6 hours, 6 to 8 hours, we have started doing dysphagia assessment for the patient. And luckily, we have identified many cases who were having dysphagia, and we collaborate with the physiotherapy team. We started giving dysphagia exercises to the patient. We have trained them, trained the attenders and nurses. We made some link nurses in the group so that in the absence of the rehabilitation nurse, the link nurses can do the dysphagia screening. Emergency nurses and the neurology ICU nurses were trained for doing the dysphagia assessment. And the tool we used was guest assessment tool, and we make a dysphagia kit in every department, so that after 2 years, I have done analysis on the data which were collected during this study, and around 60 to 70% of reduction in the aspiration cases were happened. Another thing we had done was, so many patients were satisfied also, because after giving a good education to the patient, attenders were also involved in the thing. So they were going from here, from the hospital, like fully satisfied. And we have introduced a 24-hour helpline number for nurses. The spokesperson will be handling the 24-hour helpline number. In case of any queries from the public, the spokesperson will be answering that. If the spokesperson is not able to answer, she will connect with the physician, neurology physician on duty, and they will be clearing the doubt. So that the public question regarding the BFAST, the symptoms of stroke, will be analyzed and cured early. And we got so many patients at the point of golden period. So this was the 2-3 things we have done in a hospital, and we have awarded as the best stroke care hospital by WSO. Last Diamond Award, we got Diamond Award on best stroke care from in the Fortis Healthcare last 2 years. So that was the initiative we have done, sir.
Perfect. Fantastic that what you are doing at Fortis. Yeah. I will come back to Dr. Udit, that holistic care in a stroke patient is incomplete without proper physiotherapy, post-operative or post-discharge, without proper speech and audio therapies, right? How do you think that what more can be done through the speech and audiology interventions in a stroke patients?
So by now we know the importance of multidisciplinary care in managing a stroke patient. So what is the further steps we can take is to empower that process. So first, I think any health institution which is involved in stroke should make a specialized team of neurologists, physical therapists, nurses, audiologists, and speech language pathologists, and they should work in a very coordinated and well-planned manner. Second thing is there should be some standardized protocol in place for assessment or management of each of the problem which a stroke patient can get. Now, there can be certain institution where all the facilities may not be available at one place. So in that case, there should be a proper referral system. There should also be a scope of tele-rehabilitation and telemedicine in this, so that we should be able to help the patients in the remote places. Then professionals, the multidisciplinary professionals, they should regularly meet and educate each other regarding their functions, which is very important because the awareness of that is very less. And lastly, the teams which are already very strong, they should continuously conduct some training programs so that new teams are established. Right?
Right.
Thank you.
Great. Thank you all the panelists. And before we conclude, I think we open the session for a quick question and answers. So if anybody has any questions to the panel, feel free to ask. Yeah. I'll come back to that. Yeah. Okay, so we will just give a couple of minutes to each of you for closing remarks. You can start.
Regarding the, so this is what should be happening. I was there in Canada, and I was, I've been seeing various stroke, and whatever I was speaking was based on my experience over there. So the teams which I was talking about, they have all these team in process. And it's not like, obviously, when the patient arrives at the hospital, he is in emergency, And at that time, audiologist and speech language pathologist role is not that significant. But then we should be taking care of all these things, because in the end, the quality of life is very important. And the problem which they face over the period of time, we should take care of it. So it's not only the assessment and management when they are in the hospital. We should keep a regular follow-up or screening of all these problem over a period of time, annually, on an annual basis, also. Right. Thank you.
Dr. Pallab?
Yeah. Regarding the research component, my closing comment would be that it is always advisable to do a collaboration, understand the requirements from the clinician, and as I was discussing with Professor Surya during lunch, so the neuro rehabilitation aspect has also to be looked into. It is not only the drug which should go alone, it should be drug and devices together can move for the cure of the stroke.
Thank you. My closing comment would be, because there is a varied spectrum of audience, that right patient at right time at right place, we all know three right, but in the right fashion is very, very important to manage this acute stroke patient. And most important lacuna is identifying early the stroke patient. The first obstacle would be the patient himself or patient's family, but that is with the more community awareness can be improved. But most importantly, once they land up in the hospital, whether it is emergency department or the other areas of hospital like wards or ICU, we should identify the stroke patient very early in a right fashion and then work as per the hospital protocol.
Thank you, Dr. Shah. Thank you, Dr. Biren, for wonderfully moderating it. As my closing comment, what I would like to do is open your mind. And one of my favorite quotes that I always love to always keep in my mind is from Henry Ford, the man who founded the Ford car, the motor car. He said, if I had asked people what they wanted, they would have said faster horses. Nobody would have asked him for a car. Now, when we look at the stroke, early recovery, we're looking at 8 Ds, like I said. The first 4 are in pre-hospital care. A lot of high-quality work is happening inside the hospital. But can we now start looking at pre-hospital care? I'm thankful to QAI for coming up with the guidelines, not just for stroke, but they're also now working on pre-hospital care accreditation guidelines. We have ICMR, our good friend Dr. Ganesh is talking about, do we really need physicians to treat outside? And now we have pre-hospital care bringing you 5G ambulances where the doctor can actually see what's happening to the patient. So I think, yes, you're doing great inside the hospital. Can you now start looking outside the hospital? And RED is bringing a platform where we're saying this is uniform care across the country, and then you can implement the level of care that you want, probably outside the hospital, and save more lives and improve your quality indicators. I think that's what I'd like people to think about.
So I would like to say that it's not only the responsibility of the doctors, like neurologist or the neurosurgeon, to care the patient. It's the responsibility of the whole multidisciplinary team, all the stakeholders of all the department, to do a prompt care for the patient in timely manner. So thank you so much.
Thank you to all the panelists. Now I think we are clear that how best we can collaborate. And as part of the audience, as part of the citizens, the least that we can do is that primum non nocere, first do no harm. So whenever we are on the roads, even if there is a 5G enabled ambulance with a stroke patient, nearby there is a setup which is ready, strokes approved or accredited center. But what if we don't give way to the ambulance to reach to the hospital? And that is the scenario of today's jam-packed cities or metro cities, right? So what we can do, the least, is to give the way to the ambulance and encourage others to do the so, right? And thank you very much for the opportunity. Thank you, VH, for the excellent session. Yeah, you have a question? Yeah. Yeah, please. Mike.
One is on multidisciplinary team. Second is on research. So, it's the time has come when one need to collaborate, whether it is interdisciplinary or transdisciplinary or multidisciplinary. It can vary from place to place, person to person. If you are practicing in a small city near 100 kilometers from Ahmedabad, you cannot look for the multidisciplinary team. So one cannot be, rigid about certain things. We need to create, and if you have a nurses, the one person can be a multidisciplinary team. You can train them. And that's where in India now, the most important thing is, I do not know if you all are aware about it, is AVERT trial, but the family-based rehabilitation or home rehabilitation become an integral part along with tele-rehabilitation. So these two things will become a norm for the long-term rehabilitation, which will be low cost and which will be easy to do it. And we got a lot of data, and I can talk for hours on these data, that how the family-based rehabilitation along with the latest technology could be much cheaper as compared to the person going to the best of the rehabilitation center. So we got data. I just presented in World Congress of Neurology. So we need to look at who is going to give therapy at what place. And obviously, if it is a top-of-the-line center where multidisciplinary team has to work, ideally all stroke patients should be seen by the rehab specialist within 24 hours. And then depending on the necessary need, they should be evaluated. And as you pointed out, we have one of my DM neurology did a thesis under my care, and he evaluated 100 cases who were admitted with the stroke. We developed a Nair Hospital swallowing assessment scale, which is being followed universally in India. I was the one who started Neuro Rehab department in Nair Hospital in 2000, first in the country. So we have developed that. So he assessed each and every patient admitted in ICU for the swallowing on day 1. And then when patient goes out of the ICU, he again did that. And when patient goes out of the hospital at home, he again did that. And the data shows that 32% patient with the stroke have a swallowing difficulty at time of admission, which goes down to 8%. And largely those who go home with the swallowing difficulty have the posterior foci stroke. So, possibly large MCS infarct or the posterior foci infarct. So that's a very valid point, because 32% patient is 1/3 of your patient has swallowing difficulty right on the day 1. Now, collaboration. This was a very interesting point, because I was in Singapore a couple of weeks before, Rehab 23, one of the biggest industry week, where all the top of the line robotics and everything, engineers, companies, they are there. And there was a panel like this, and I was one of the panelists. The most important, they were asking that how important it is that those who are developing the latest technology of the robot, that Locomoth or Amio or anything, Tyromotion, they all were there. How important it is for the collaboration. And I think the time has come when the IIT guys, engineers, neurologists, as you have pointed out, but you pointed out everybody except the most important person. That's the patient. We need to ask patient, what does he want? And the technology has to develop around that, along with the neurologist, what he desires, how it can be delivered. And then the engineer and IIT guy has to work on this. So unless we have all these come together, and this is what exactly I told them, that patient, what he desires, what you built up a very heavy machine, which patient says, I don't want to put my hand in that and do the work. What is the use of that machine? So these are the important points. I think we need to look into it. India, we are having a lot of work has been done, and I'm glad that all younger people are working hard. It's the time that we all come together and develop. Not everybody is developing the same thing. We come together and develop the things which are meaningful all together, take a different part. Because everybody is now making mobile app, everybody is making their own app. We can make one good app which can be used to million patients. Thank you for me.
Excellent. Thank you. Thank you. Big round of applause for the entire panel. Thank you very much.
Thank you so much, panelists, for that engaging discussion. I would request Dr. Biren to please felicitate his co-panelists now. Dr. Pallab Bhattacharya. Dr. Sanjay Shah. Dr. Tausif, Thangalvadi. Miss Athira, Hareendran. Dr. Udit, Saxena. And now I'd like to invite Ms. Pinky Chahar to please felicitate Dr. Biren. I request you all to please come forward for a group picture. Thank you so much, everyone. May I please have a round of applause for the wonderful panel discussion.